Welcome to the Long COVID podcast with me, Jackie Baxter. I am really excited to bring you today's episode. Please do check out the links in the show notes where you can find the podcast website, social media and support group, as well as a link to buy me a coffee if you are able. You should not rely on any medical information contained in this podcast and related materials in making medical, health-related or other decisions. Please do consult a doctor or other health professional. I love to hear from you. If you've got any suggestions or feedback or just want to say hey, then please do get in touch. I really hope you enjoy this episode, so here we go. Hello and welcome to this episode of the Long COVID podcast. I am absolutely delighted to be joined today by Dr. David Putrino, who doesn't need a lot of introduction, doctor and researcher and all-round wonderful human. We're going to be diving into, the what can we of long COVID and how that's informed by a lot of the latest research and what's showing up, I suppose, anecdotally as well as researchally. I think I just made that word up. So a very warm welcome to the podcast today. It's so lovely to have you here.
Oh, thank you for having me. No, it's always great to chat with the community and talk about what's going on.
Amazing. So before we dive into all of that, can you just say a little bit about yourself and what it is that you do?
Sure. Yeah. So my sort of official title at Mount Sinai is I'm a professor in the Department of Rehabilitation and Human Performance. And the Mount Sinai Health System, which is this, sort of big hospital system in New York, they also call me their Director of Rehabilitation Innovation. And in that role, it's my job to identify new technologies, new treatment approaches, things that can help different communities and different populations of patients and accelerate the path of those treatments or cures or approaches so that they can be used in common clinical practice as quickly as humanly possible. So my background before COVID was very much around implementation science for new technologies and new cures and new treatments. So we really, if there's something out there that can be helping patients, we want to get it into the hands of patients as quickly as we can.
Absolutely. And I think a lot of your focus at the moment is kind of around the sort of long COVID space.
So at Mount Sinai, I run 6 centers, and each center has its own specific clinical focus. And we do everything from pediatric rehabilitation for kids with cerebral palsy and spinal cord injury through to brain-computer interfaces for people living with ALS. We work with athletes. We work with people who are living with chronic pain. And we do also have a center entirely focused on infection-associated chronic illness. So that's where we see folks with long COVID, with ME/CFS, with fibromyalgia, with hypermobile EDS, chronic Lyme, and other tick and vector-borne illnesses. So it's a busy space, but I would say that right these days, a lot of my attention is focused on these illnesses and trying to both do research and improve clinical practice strategies for patients.
Yeah, that's a lot of hats to wear.
It is a lot of hats, but I mean, I am eternally fortunate that I have this amazing team of really smart, motivated, passionate folks who really share the mission and try to get things out to our patients.
Yeah, absolutely. Now, when you were saying your role or your job title, mentioned the word rehabilitation, and I think it might be a really good idea to just clear up what that actually means, because I think it can be misinterpreted in the way it's heard, but possibly also the way it's spoken. Because I think to me initially, I would have said, "Oh, rehab, that's like increasing your exercise capacity after you've had a setback." But what I've learned while I was unwell was actually that rehab could mean that, but it also could mean a whole host of other things like breath work or pacing and all sorts of other things. So I'd love to hear your kind of thoughts on that and maybe if that's changed over time.
Yeah, no, I think rehab is a very broad field, and actually, when I joined the team at Mount Sinai, we actually changed the name of our department from the Department of Rehabilitation Medicine, which it had been for over 100 years, to the Department of Rehabilitation and Human Performance to sort of really put out there the idea that this concept of rehabilitation medicine should include a whole spectrum of activities up to and including, hey, I'm feeling fantastic, but I wonder if I could feel even better. I wonder if I could enhance my performance further. And so the work that we do runs the spectrum of some of the best athletes in the world who are working with us on actionable strategies and novel technologies to perform even better. There's not an injury. We're not doing sports medicine. They're just trying to push the limits of human performance, which I actually think the more I learn is highly relevant to long COVID, and maybe we will discuss that at some point. And then there are folks who are living with disability, and the role of rehabilitation medicine in that space is to either apply techniques that will help them to improve their functional capacity, so improve the sort of breadth and sort of repertoire of activities that they are able to perform independently, um, or teach them strategies to sort of avoid worsening of their illness. And so, on the one hand, when we're helping people to improve their functional capacity, I want to be clear that that is not always the same um, as saying, let's cure the problem. Um, so often it's saying, oh my goodness, you have an energy envelope and you burn through your energy envelope that much faster if you walk. How about we get you a wheelchair? You know, that is an example of something that can massively increase someone's functional capacity without focusing on rehabilitation, exercise, etc. Um, Also, in the domain of preventing people from getting worse, we have things like pacing and strategies like pacing, where we try to understand, okay, well, what is your energy envelope actually, and how can we equip you with techniques that will help you to, stay within those boundaries. This also involves a multidisciplinary approach. So we work with psychologists and psychotherapists who will help patients with um, coming to terms with the emotions that come along with being newly disabled, and helping just go through the adjustment of um, coming to terms with the fact that you have a diagnosis that means that you have a recognized disability under the Americans with Disability Act, or at least for right now, that is a true statement. And and what that means for you, and what that means for your identity, and how you navigate that and move forward. We also have neuropsychologists who will help with techniques such as cognitive remediation therapy that can help you acknowledge, okay, my cognitive capacity has changed, but if I apply these techniques, I can often function at a near to the same level, you know, um, and work through that. We have nutritionists who help people address new onset food sensitivities and allergies, issues of that nature. We have social workers who help with loneliness and social connection and social isolation, and introduce folks with long COVID to one another so that they have a little sort of support group, often in their neighborhood. We try to match people up by zip codes so that, you've got a few folks who, are, if you're COVID conscious, they're also being COVID conscious. Um, uh, if you're not up to hanging out, they're not going to hold that against you. They're going to say, yeah, I get it. You're in a crash. Let's just text, or, something like that. So all of this falls under the umbrella of rehabilitation medicine, and helps us to uh, help folks with different diagnoses live full lives, or as full as they can, um, given the severity of their diagnosis.
And I love this idea that, it's putting supports in place to do the best you can for each individual person, which isn't always the same because everyone's different. But you're able to do this with all these kind of different branches of your umbrella of rehabilitation. I don't know if umbrellas have branches, but right now they do. So I think that's great that it's this broader approach rather than the traditional kind of, I don't even know if it's the traditional model, but I think it is what a lot of people who don't know understand traditional rehabilitation to be. So this is awesome. I'm gonna jump on something that you said quite early on because I thought let's just do it. Where you said that the sort of the upper level, of what people can physically do, your athletes that are, rather than wanting strategies in order to get well, are wanting strategies in order to hit those PBs and break those records and, run further than anyone's run before. And, these things that when we're unwell seem like, not even completely out of reach, just kind of like insulting that people can actually do that sort of stuff while I can't move off my bed kind of thing. And you said that that does have relevance to the long COVID world. So I would love to hear what you kind of mean by that, because I think this is fascinating.
Yeah, I just mean that often when we're working with these extremely high performance athletes, uh, we're often looking for ways to extend the capabilities of their energetic systems. So, okay, what are we trying to do? We're trying to make their mitochondria more resilient to overexertion. We're trying to make their mitochondria more efficient. We're trying to eat up reactive oxygen species that cause oxidative stress in the athlete, meaning that they produce a lot of waste products. And so a lot of the techniques that we do for that, so things like oxaloacetate as a mitochondrial support, CoQ10, NAD+, all of these technologies that enhance the Krebs cycle in our mitochondria and make our mitochondria more efficient and help to take out the trash a little bit. Things like hyperbaric oxygen therapy, that make oxygen more bioavailable and improve the sort of capillarization. So, get more capillaries and more blood vessels to be created and supply tissue with resources. These are all things that have been used in athletic communities for decades. And as we start to think about this, and also as we butt into longevity science as well, and we look at people who are taking things like mTOR inhibitors at low dose, like rapamycin. What does rapamycin do? It makes your cells more efficient at generating energy. It boosts your immune system so you can fight off pathogens. These are interesting topics as we learn more about long COVID, as we learn more about these infection-associated chronic illnesses, we start to see maybe a framing for these illnesses is that they're illnesses of accelerated aging. They're illnesses that accelerate cellular aging. And so some of these techniques that people are using and have been using, again, for decades, metformin, low-dose rapamycin, these are things that, many people in the long COVID community who may be listening to this are nodding their head going, oh yeah, metformin did give me a little boost. Rapamycin has been helpful for my friend down the road. So it was an unexpected sort of discovery that what we've been feeding these athletes for so long actually makes some sense here. But the more we learn about the physiology, the more I learn from absolute genius researchers like Rob Wust, who again has just worked in elite sports for a lot of his career and understands muscle physiology and the generation of energy so well. We start to see that there could be two sides of the same coin.
We'll be right back. I'm interrupting myself for a second to tell you about long COVID breathing. The fabulous Vicky Jones and I have teamed up to bring you long COVID breathing. We are both passionate about sharing our expertise and experience of the breath and how incredibly helpful that can be with long COVID. We've worked together to develop a course that is specifically tailored to those with long COVID. It's a 6-week course with 12 sessions, all delivered online. The community feel and learning that we're all sharing is such a joy. To find out more information and to sign up for our courses, workshops and other shorter sessions, please check out the link below, longcovidbreathing.com, or email longcovidbreathing@gmail.com to start your breathing journey with us. So even though these two groups, your elite athletes and your people with long COVID, are so complete ends of the spectrum, it's still about those little tiny margins, those little tiny gains, making the most of what you have, and all of this sort of supporting the body as much as you possibly can in all these different areas. So yeah, they seem very disparate, but there's an awful lot, as you just said, of those parallels. Yeah, I mean, I say this day after day after day, breath work is my area. But we learn these breathing exercises because we have to, in order to help us to get better, to be able to function better, to feel better day to day. But they're tools that will help us every day of our lives, and I live and breathe that every day. So all of these things that we're doing are things that are or can be certainly applicable to many people, not just people with long COVID. And yeah, I think that's amazing. So you mentioned all these sorts of different areas, and you must be seeing this kind of day to day with the work that you're doing, that all of these things are helping people to either see a bit of improvement or to stop them from getting worse. And is there, you mentioned these two categories, the seeing improvement and the preventing backslide. Are they the same things that people are doing that do the going forward or the stopping going backwards, or are they different, or is it different for different people?
No, I mean, I think, um, from our perspective and from the perspective of our clinic, we think about long COVID as, a diagnosis where people have many common symptoms, but many different drivers that are pushing those symptoms. So, if you read any paper that's been published in the last 5 years about long COVID, where symptoms are being cataloged, the symptoms that are at the top. Now, this is not saying that everybody has these symptoms, but it is saying that these are the most commonly reported symptoms. You'll get fatigue, usually number one, post-exertional malaise. People talk about a sort of a racing heart rate. People will talk about headaches and migraines. People will talk about GI disturbances. And then, as we know, there's over 200 different symptoms, but, those are invariably sort of the top five. And what we know to be true is that those symptoms can happen for a number of different reasons. And often we actually need to delve in a little bit deeper, because sometimes when somebody tells you that they're fatigued, what they actually mean is that they have post-exertional malaise. Sometimes when someone tells you they're fatigued, what they actually mean is that they're sleepy all the time. And you need to sort of tease those apart, because someone who tells you that fatigue is their most disabling symptom, well, we've seen some great work, and I know that you had the incredible David Joffe on the podcast at one point, who I love, and I love the way he explains things, and but you look at the work that he's doing, and he's seeing really disrupted slow wave sleep in a lot of folks with long COVID. And if you fix that, with something like Provigil, or a medication that is often used for narcolepsy, but can be used to stabilize shortwave sleep. A lot of these folks who are having crushing fatigue they're back to normal. They're feeling actually pretty good. And this is the phenotype of, I can't, I can get to sleep just fine. That's what they usually tell you. But then a couple of things that usually sort of tip me off that we're dealing with something like this is usually very vivid dreams and lots of dreams. Can sleep as long as you'll let them sleep. Like if you know, like if you let them, they'll go all the way into the afternoon. And then no matter how long they sleep, they feel unrefreshed. And that's the that's the pattern. And that's the pattern where they're skipping the slow wave sleep, they're staying in REM, and no matter what, they're just not getting to that restorative slow wave sleep. So that can be one form of fatigue that can be treated in one way. Other people can have fatigue because they have autonomic nervous system dysfunction, and so now we're seeing an overactive sympathetic nervous system, which means that their heart is racing. If they push themselves beyond a certain point, which triggers an overactive sympathetic nervous system response, then they will click back the other way after that exertion into their parasympathetic nervous system, their rest and digest part of their nervous system, and they'll just crash, and that's all the work that they're going to do for the rest of the day. And then sometimes you'll even see, despite this extreme fatigue, folks with dysautonomia will experience the tired but wired feeling. So they've crashed, but their sympathetic nervous system still isn't letting them get to sleep. They're still full of adrenaline, and that's where things like breath work and using parasympathetic breathing techniques have been so instrumental in bringing things down. So again, we said at the beginning we could probably go for 10 hours, but we could go on forever with all of the different rabbit holes of. But I think the main thing to remember is what clinicians need to do is understand the symptoms, catalog the symptoms, listen to the symptoms, but also understand that there are going to be different drivers that are causing these symptoms. And so the true, the real important piece is less about, I often get asked, like, how do you treat PM? What's more important is what's driving the PM. What is the cause of the PM? Why does someone have fatigue? Why do they have GI issues? Let's figure that out, and then there'll be a treatment.
Yeah, so it's kind of understanding what's going on underneath, what could be causing this to happen. Because as you say, sleep, we know that sleep is super important. Sleep is super important for everyone.
Yeah.
And before I became unwell, I did not get enough of it. But I could have a rubbish night's sleep, have an all-nighter, and the next day I would be grumpy. And I would probably eat far too much, but then I would get a good night's sleep the night after and everything would be fine. Whereas, when you have long COVID, that is not the case. You get a rubbish night's sleep every single night. You never feel refreshed, and it makes you feel worse and worse and worse, and the cycle continues.
Mm-hmm.
So, by being able to even improve that sleep just a little bit, is absolutely huge for someone who is really struggling with sleep. And still going to help someone who's struggling a bit with sleep. So as you say, that will then probably have a knock-on effect onto all sorts of other things too. That maybe their fatigue isn't quite so bad, or some of their other symptoms maybe, even if they're not improved, they're maybe a little bit easier to handle. Or, what happened to me was that I found something that helped me. And then suddenly I was able to see the wood for the trees and see a little bit more of what was going on elsewhere. So I think, yeah, just because there isn't one cure doesn't mean that there's not so many things that can be done. And the more you kind of clear the decks a little bit, the more you can kind of see those little whack-a-moles that you have to go after that, isn't it?
Yeah, exactly.
I'm full of the analogies today.
Absolutely.
So,
Yeah, and
yeah.
and I think our strategy early on was we wanted to focus on things that we could help with. So, like one of the first papers that we put out, after identifying long COVID as a symptom in 2021. We said, we're noticing that people with long COVID have like hypocapnia, low levels of CO2 that they shouldn't have, so that's where we started to talk about breath work at that point in 2021. Then we started to notice, POTS was extremely prominent. So we started to look into autonomic rehabilitation. We started to publish papers about drugs like ivabradine, pyridostigmine, all of these POTS drugs that can sometimes help. And now, as we've learned more about persistent pathogens, as we've started to publish on chronic inflammation, autoimmunity, reactivation of old pathogens, as well as persistence, we're moving into clinical trials of medications that can maybe address these issues. Now, the problem that we're running into with these approaches is these are complex issues, and what we're learning is, we're running into this problem of, for the last 100 years, people have really sort of said, hey, we know that EBV sticks around your body, Epstein-Barr virus, but it's no big deal. Like everyone has it, and don't worry about it. Don't worry if it reactivates. Now we're learning, it probably kind of does matter in some people if it reactivates. But we don't have good drugs to address pathogens that have become chronic in the body, because those pathogens, unlike acute pathogens, which are in your bloodstream, they're very available to your physiology. These pathogens hide. They hide in tissue. They hide, they hide elsewhere in immune privileged sites. And so we did run a clinical trial of Paxlovid in collaboration with Yale University and Akiko Iwasaki and Harlan Krumholz, who are amazing collaborators, and it failed. We are still doing subgroup analysis to understand who it helped and hopefully why it helped a small percentage, because a small percentage did experience benefit. But also, when we were looking at Paxlovid, it was, it's known that Paxlovid does not penetrate tissue. And so even though we were trialing it out and we wanted to see, because, there is a percentage of folks who have circulating spike in their blood, and we want to try and understand what's going on there, and whether or not, this could be a subset that benefit from something like Paxlovid. We also know that if your persistent SARS-CoV-2 is hanging out in your gut, or it's hanging out in, your muscle or breast tissue or lymph, Paxlovid isn't going to do much to address that. And so, now, in addition to up leveling our understanding of persistent pathogens, reactivated pathogens, so on and so forth, we also need to start thinking about, okay, how do we target these things in folks where it may be an issue?
We'll be right back.
Hey there, I'm just jumping in for a second to see if you're enjoying this episode. If you're finding it useful, maybe you would consider sharing it somewhere, a friend, a group, or even on your Twitter feed. If everyone was able to share just once, we'd be able to get this information out to even more people who really, really need it. So please consider sharing somewhere if you possibly can. I hope you enjoy the episode, and thank you so much.
So it's bringing this all together, isn't it? Because you say, there's all sorts of different stuff being a technical
Very
scientific
technical
term,
yes.
Going on sort of underground that, we can feel in the symptoms that are presenting themselves, but we can't really see what's going on, certainly not in our own bodies, what's actually causing that. And you were talking about, obviously COVID itself, or a vaccine, or a previous infection, if it's someone with ME/CFS, or whatever it is that caused that. But it was the sort of acute infection, the acute insult.
Insult. I like insult
kind of,
because it can be exposures, it can be trauma, lots of things can trigger these disease states. Yeah.
Yeah, absolutely. So it's not even just a disease of itself, that the acute trigger. So the assault, good word, that happened has set off all this technical scientific stuff. And there's all these different things going on underneath, some of which you've mentioned, and there's all sorts of other sort of things out there. Um, and I think there's some overlap as well. Some people have dysautonomia plus persistent pathogens, and some people have, some other collection of things. And I'm not quite sure where I'm going with this. I'm almost thinking, in some ways, yes, it is important to know what's going on because then you can target certain things. But also, is there a sort of space for more broadband stuff that, if it's done appropriately and gently, that we know is going to help, like eating well, eating appropriately, breathing, again, so long as it's not going to stress the person. We're not talking Wim Hof. All sorts of other things, nervous system support, all so that people can just sort of start doing that. We know they're going to help on some level, even if we're not totally sure what all the deeply scientific stuff underneath is going on.
I absolutely think that there is a lot of space for more generalized techniques that we know to be helpful. I still think that the goal of a clinic should be pretty quickly to try and understand, even amongst, like I could throw 50 things at a long COVID, a person with long COVID, that may help, right? But these are folks with energy limiting disease. So you don't want to say, do these 50 things right away, because, that is going to be, that's going to be overwhelming. But
Mm.
certainly, our general approach tends to be, if someone comes to us, and this is often the case, they've been sick for a couple of years, completely feel very completely out of control with regard to their symptoms. Step one is we throw as many mitigation techniques as we can toward them to stabilize their symptoms. So it's not even about like, let's reduce your symptoms. Let's just get to a place where you know when the symptoms are coming and you know why those symptoms are coming, right? So that's where we like to start. And pacing is a really good example of a strategy that can help folks get there. And we also, these days we talk a lot about using computerized forms of pacing. So there's like the Visible app, there's Guava app, there's lots of these chronic illness apps that allow you to log your symptoms and give you a little bit of analysis. They're not perfect for everyone. I think a lot of people can sometimes become very fixated with like logging their symptoms. And if that's you and that makes you feel uncomfortable, I'd say, don't use the app. But if you're someone who's very data driven and it helps you to know, oh my God, like, I ate a tomato and then I started getting reflux and a racing heart rate, which we know to happen because, tomatoes are nightshades and they have a lot of histamine. That is something that can be helpful to some people. So stabilizing symptoms, then general strategies to see if we can start to reduce symptoms. So that's when we bring in, um, different rehabilitation techniques. That's when we're starting to talk about things like vagus nerve stimulation and ramping up the breath work a little bit. Like there's breath work for stabilizing symptoms. Then there's breath work that is, as you know, I don't need to tell you, like actual work. It's hard to do. You wouldn't give it to someone with unstable symptoms because it's pretty tough stuff. But it can actually get them feeling better and having reduced symptoms if they commit to it. And this is where we also pull in a lot of different supplements. This is where antioxidants can be really helpful. This is where working with a nutritionist, not just to cut out, go low FODMAP, or whatever. It's really to not just identify the foods that trigger you, but also build a meal plan where you're getting adequate nutrition. We see so many folks who, when they start working with our nutritionist and they actually start getting enough protein, they actually start getting enough calories in a day because they know what hurts them. So they know instinctively, okay, I'm not going to eat that. I'm not going to eat that. That leads them with like three healthy foods, safe foods, and so by the time they get to our nutritionist, they're malnourished, and they're not getting enough nutrients, and that can lead to all sorts of problems. So then working with a nutritionist to actually get them enough, enough protein in their life, enough, carbs, etc., is extraordinarily helpful. So I do think that as we're waiting for all of these more precision targets to come out, as we're running clinical trials on some of these targets, there's a lot that we can be doing in the meantime.
Yeah, I think so. And you just sort of alluded to it, there's a million different types of breath work, right? And I think, expanding it beyond breath work, there's a million different types of strategies, of diet plans, of pacing plans, of ways of pacing, of ways of doing all of these different things. And it's, the right strategy for the right person at the right time, isn't it? If you start talking about certain things when someone is, rock bottom, they're not able to access that. So it's finding, okay, what is going to work for you in that situation? Whereas once things have stabilized a little, maybe symptoms have reduced, maybe they've seen a little bit improvement in their functional capacity, then different stuff is available to you, isn't it? So it comes back to that, okay, what can we do in this moment? Because even if it's a tiny, tiny, tiny bit, it may then level you up, even if it's 1%, to the point where you then can access some of those different things. So it's, yes, there's so much that can be done.
Absolutely. And then again, we I don't want to get too far into the weeds, but but we can also, it's also the point where once you start to stabilize symptoms, once you start to sort of do some of the safe things, that are kind of generalizably good for everybody and can give a little bit of function back. Starting to delve into the symptoms with a little bit more precision, starting to just try and understand why someone is feeling a certain way becomes very important, because some of the more active interventions can also be harmful if they're misapplied. So, for instance, we sort of generally, often, all too often, we generally just talk about POTS, or we generally just talk about dysautonomia. But, there are some folks who have POTS, and their POTS will take the form of, if you have them lying flat on their back, they'll be hypertensive, they'll have high blood pressure. And if you get them going from lying flat on their back to sitting to standing, their blood pressure will drop, right? And then there are other folks who are the exact opposite. These are the folks with what's called hyperadrenergic POTS. You have them laying down flat on their back, their blood pressure is pretty stable and normal. By the time you get them standing, their blood pressure is just increasing nonstop until you get them laying back down again. So understanding that, like, just because the doctor says that you have POTS doesn't mean that necessarily, you should be overloading yourself with fluid and taking one particular drug. Understanding that, there's specific approaches to the different type of POTS that you have, and a good clinician is going to help you figure out, like, what is your physiology doing when we're moving you about, that can give us a clue as to the interventions we should apply, rather than, again, just saying, oh, POTS, okay, everyone gets ivabradine, everyone gets, an IV bag of saline. That's not necessarily going to be helpful to everybody. And these are the sorts of things that not only can be harmful to patients in a clinic, but can also be harmful to the science when, there's a sort of, hey, let's run a clinical trial on ivabradine and give everyone who meets POTS criteria ivabradine. Like, that's not a good idea. That's going to lead to a failed clinical trial where you then say, well, ivabradine is not a useful drug for long COVID POTS, when it actually is. It's just for a subset, and yes, if you find the wrong subset, it makes people a hell of a lot worse, or it does nothing, but in the right subset, it can be life-changing.
Yeah. So one umbrella term, many different presentations. And it comes back to, doesn't it, whether it's a doctor or a practitioner or a nurse or, whoever you're seeing, it's that practitioner, that doctor should be looking at each person individually rather than coming in with assumptions, I suppose, doesn't it? What are you bringing to me today? And what are we going to actually do about you, not about what I assume is going on with you, whether it's dismissing their symptoms entirely or saying, I read about POTS, this is what we do with POTS. And as you say, maybe it is for some people, but it's not for everybody, and that person is an individual.
Exactly. And we could say this for all of medicine. Of course, this is an obvious and a general statement, but when it comes to complex chronic illnesses, I think it just becomes much more evident that our health system is not set up for precision. It's not set up for thoughtfulness. It's not set up for personalized medicine. What it is set up for is very sort of skin deep algorithmic medicine. So it's like someone comes in, the doctor takes a look at them, and exactly within a few seconds makes some assumptions about what they're looking at and says, oh, you fit in this box, which means you get this, this, and this. That's how we want medicine to be. And one of the things that I'm always advocating for when it comes to complex chronic illness is we need to look at other complex illnesses that have been managed well. So, the HIV world is an incredible world to take some knowledge and take some wisdom from. The world of cancer and cancer rehab cancer rehab, cancer treatment is a really good place to take some inspiration from. I often sort of bring up the example of when we were in the late 80s, early 90s in cancer. The sort of level of understanding that the medical profession had of cancer was, Susan Sontag, who's a wonderful author and a poet. She wrote about this in one of her books, but she was diagnosed with bowel cancer, and she was told that she had the cancer personality, and she got her cancer because of the way she lived and her personality. And so she then, being the brilliant sort of incisive person that she was, she went on to write this whole book about how we metaphorize illnesses that we don't understand. And so she was told she had the cancer personality because the medical establishment didn't understand cancer. So they were just like, you've got it because of how your personality is. So that was cancer in the 80s and 90s. Now cancer in 2025 is you get a personalized treatment based on the type of tumor, your genetic background, your past medical history, your gender, your race, your age. All of these are built in to the computational algorithm that determines the drugs that you get. That's where we need to get to with complex chronic illness. And unfortunately, for the last 50 or 60 years, these are illnesses that have been largely held in the domain of psychology and psychotherapy and psychogenic illness. And so we haven't been able to make this progress. Now, with long COVID entering the scene, and a big increase in the amount of research that is being done across the board in these illnesses, these complex chronic illnesses that are triggered by infection or other sort of physiological insults. We're really starting to see that these are biological illnesses. We're really starting to see that multidisciplinary approaches are needed, and very highly personalized approaches are needed.
Yeah, and I think, that the personalized is so important, isn't it? Because you could do, you were talking about using ivermectin for POTS earlier, and that, depending on which subset of POTS you have, that will work beautifully, or it will be a total disaster, and possibly a whole spectrum in between,
Yes,
for all those other subsets, and any intervention or treatment has got to be personalized, isn't it? Because every person, as you said, is a different gender or a different race or a different weight, or their presentation is different. So whatever it is that you're doing or taking or whatever, is has to have that kind of personalization. And I think this is what you were kind of alluding to earlier about the sort of very structured box-like nature of medicine. You go to your doctor, you have whatever it is, they give you this pill and you take it. And that's a very simplified version. But what if you had one person who was a totally different race, gender, weight, and something else? Surely even just that one very simple drug that they're taking is going to have different effects on two different people, with differences in them. So I would have thought even just down to very simple, taking your ibuprofen out of the cupboard. Surely even just with something like that, these nuances are still going to be felt.
absolutely. And that's I feel again in almost every aspect of medicine, you can really go down this rabbit hole and be highly, we should be striving to be as highly personalized as possible.
Mm.
We know that, for decades and decades, this is not an opinion. This is documented fact. We know that um, women were more likely to have adverse reactions to drugs because the drugs were tested in disproportionate amounts of male research participants, even male animals. Like even when they were doing the rodent studies, they were doing them in male animals because ironically, they didn't want the noise from the menstrual cycle of the rats to influence the outcomes of the drugs. And I was like, yeah, the noise is the point, right? Like that's where you understand, like, um, and
Heaven
then
forbid us women should make things difficult for men.
and exactly, and in addition, it's like even though some lengths are being taken to improve inclusion of women, inclusion of female animals, etc. If you were to walk into a doctor's office and ask about most medications, not all, because some they do have this information, but for most medications, if you were to ask, is there a particular point in my cycle where I should take this drug? Most doctors will look at you like you've got three heads when it's actually a very fair question. Are there points where estrogen surging through my body is going to cause this drug to be more or less effective? And should I be aware of that in some way? And the reality is we actually just due to years of neglect, we don't have answers to those questions. And now take that statement that I just made about women and multiply that for communities of color, for other historically excluded groups in healthcare. And we have, an enormous amount of diversity that we need to be actively accounting for. And we need to stop pretending like it's not there. We need to embrace the complexity. But not to sound overly cynical, but every time you ask a drug company to embrace complexity, they're like, well, okay, well, how much is that going to cost? And how long is it going to take me to get this drug to market if I embrace complexity? Um, and you know, honestly, to me, it's pretty straightforward calculus. That's the reason that a lot of these things are taken out of the equation simply because they're bothersome and they stand in the way of medications making money.
Yeah. Which is pretty shit,
It's pretty
isn't
shitty.
it? That's pretty shit.
Yeah, absolutely. We can
Um,
say that.
it is. But it's also highly relevant to long COVID because, I'm pretty sure the stats say that women have a much higher proportion of women have long COVID than men. And that's not to dismiss the men who are having the experience. But I think when I saw it before, it was 5 out of 6 people with long COVID are women. I don't know if that's the up-to-date one, but it's pretty skewed, isn't it?
There does appear to be a skew. I think the literature I'm familiar with points to 65 to 70% of long COVID cases. And Akiko and I have a paper under review right now looking at um, the role of hormones in presentation of long COVID symptoms. And lo and behold, it appears to be related to testosterone. And it appears that testosterone may be in some ways protective uh, from people experiencing severe long COVID symptoms. And again, this is not to say that there are not men out there who are experiencing extremely severe long COVID, because of course there are. But you know, when you look at similar trends that have been seen in fibromyalgia, similar trends that have been seen in POTS, similar trends that have been seen in ME/CFS, over the years, it's all been explained by, well, women have a higher propensity for anxiety and depression. And these are not my words. These are published literature in systematic reviews when asked, when leading experts in this field were asked, why are more women being affected? And the thing that always blows my mind is if you ask the sixth grader who had just started health class, like hormonally, what's the difference between men and women? They would say testosterone. And yet it didn't cross these scientists' minds to say, why don't we look at testosterone levels? And, the minute Akiko and I looked, it was, a very clear trend that not only were folks with long COVID experiencing testosterone depletion, but the lower that testosterone went, and also in men, the lower estradiol went, because as men, because we don't have ovaries, we produce estrogens through conversion of testosterone. So it can also serve as a sort of relative marker of our testosterone levels. The lower those hormones went, the worse symptoms were being reported. So, there are, for those who are sort of intellectually curious and willing to listen to the community, there are clues everywhere as to what's going on and how these illnesses are affecting our bodies. And these are the sorts of dots that you need to try and put together if we're going to come toward, actionable treatments.
Yeah, I mean that's huge, isn't it? Like the sort of testosterone stuff and the hormone fluctuations, because it's been documented certainly since very early in long COVID. And I'm pretty sure since, many, many years before in the ME/CFS community,
Mhm.
that fluctuating hormones and fluctuating symptoms are, very much a thing that go side by side, sorry.
Yeah,
So yeah, it's like, okay, well, why? Why is
exactly.
this happening? And let's dive into that kind of thing. So I think, yeah, that's amazing that is now happening. I feel like we need to talk more about that to do it justice and don't have time. Um, so I think just maybe finally, you mentioned earlier in your, I think 6 different hats that you wear, that one of them was the sort of the long COVID, the ME/CFS, the fibromyalgia, all of the sort of infection associated chronic illnesses. You used a much better word than that. And they all sort of fit under the same hat. And, we know that there's a lot of commonalities in presentation, there's a lot of commonalities in terms of some of the things that help. So under your sixth hat, are you sort of treating all these illnesses as the same with these myriad different triggers, or are they very separate? What's your kind of approach in there? And is all this research that we're doing in long COVID also going to help all of these other people who have been suffering so much for so much longer?
Yeah, I think again, it's we need to. It was very intentional to study all of these illnesses and treat all of these illnesses under the one banner. And the reason for that is these are still not well characterized illnesses. And when I say not well characterized, I mean that, when someone receives an ME/CFS diagnosis, just like somebody with long COVID, their symptoms may be driven by a myriad of different things. It can be driven by mold exposure all the way through to persistent enterovirus infection. It can be driven by chemical exposure and heavy metals in their blood. So these are all things that can drive symptoms in an ME/CFS diagnosis. Similarly, in folks with long COVID, sure, COVID was the trigger, but we're starting to see some really wild things in the blood work that we're studying. So, again, everything from autoimmunity, which requires autoimmune drugs, to reactivation of bacteria and parasites, Babesia, Bartonella, these are things that we're seeing in our research, to POTS and autonomic nervous system dysfunction that requires blood pressure medications and fluids and salt and things of that nature. And so I think that certainly what we're going to learn over time is that there is a precision approach for everyone. And the person who has long COVID because they have persistence of SARS-CoV-2, that person is going to need, a combination monoclonal SARS-CoV-2 antiviral that probably won't help anyone else in this bucket of conditions, right? It's just going to help that person with long COVID. It's not going to help someone with ME/CFS who's been sick for 30 years, someone with chronic Lyme disease. But the person who has long COVID because they got COVID and it reactivated an old Babesia infection that is now chronic. I'm really glad that we've got Lyme, chronic tick and vector-borne illnesses in the clinic who are going to say, oh, give that person, this anti-parasitic drug so that their symptoms will clear up. And what we need are specialists who have that level of understanding. And again, my mission in life, I think, is to make it the problem of GPs and PCPs, because they have done such a good job of managing complex illnesses like HIV, which is similar, where you sort of say, okay, well, you're infected by HIV, but you have all of these other problems going on. So this is going to be the medication, this is going to be the medication regimen for you. That's where I think we need to get with complex chronic illness in general.
Yeah, so it's bringing together all of these specialists in their own area, but in this collaborative approach. So you've got them all under one roof, I suppose, so you can literally bounce them around the break room.
Exactly. Yeah.
Yeah.
And then people can start to do what a lot of these clinicians are craving, which is start to create the more algorithmic approach to, if you see this, then do this. If you see that, then test for this, and then either do A, B, or C. Because we do need that. We do need clinical pathways. But first, we need to understand the problem better.
Sort of like following a map of the wrong area is not going to help you get where you want to go. I think I should put that on like a little quote bubble somewhere. And that was quite good.
Or looking for your keys under the lamppost, because that's where the light is. That's not going to get you anywhere either. So yeah,
No, true, where they've actually fallen down the drain just behind you.
exactly.
Uh, Amazing. Thank you so much. This has been an absolute pleasure chatting. I feel like I've learned so much. I will try to reference all these studies and things that you've mentioned in the show notes as well, if people want to follow them up. And yeah, thank you so much for giving up your time and energy today to chat with me and for all that you're doing.
Thanks for having me, and thank you for putting this podcast out. It's so important, and I really appreciate it.
Thank you so much to all of my guests and to you for listening. I hope you've enjoyed it, or at least found it useful. The Long COVID podcast is entirely self-produced and self-funded. I'm doing all of this myself. If you're able to, please go to buymeacoffee.com/longcovidpod to help me cover the costs of hosting the podcast. Please look out for the next episode of the Long COVID podcast. It's available on all the usual podcast hosting things. And do get in touch. I'd love